Hello everyone, this is Dr. Santosh Banshelkikar. I am course convener for BOS Advanced Trauma Course Virtual 2020. Based on your feedbacks in basic trauma course, we have decided to increase the duration of case-based discussion in this course without affecting the total timings of the course on a particular day. That's how we had decided to share these concept-based talks in a pre-recorded manner before the course so that you can go through these talks as per your convenience and prepare the topic to make most of it during the course timing. My job here is to share my this thing concept based talk on principles of fractures of proximal tibia. I'll be sharing it now. We'll be overviewing this topic of proximal tibia fractures on these subheadings. Let's begin with anatomy. If you look at the anatomy of proximal tibia in AP as well as lateral view, there are some peculiar points which I would like to mention. If you notice on AP view, that lateral condyle is slightly higher than medial condyle, as well as lateral condyle is less dense as compared to medial condyle. So we often see lateral condylar fractures commonly, and there is always a comminution in lateral condylar fracture most of the times. Whereas medial condyle is relatively rare as compared to lateral condyle, as well as it doesn't have comminution, and it is usually associated with high energy trauma because of this dense trabecular network in medial condyle. If you look at a lateral view of the tibia, there is a slope, posterior tibial slope of approximately 10 degrees, and you need to consider this while reconstructing all the columns of the tibia. Also, it is important to know the attachments of the soft tissues to this proximal tibial condyle, because most of the time, not only this fracture, the soft tissue injuries are very commonly seen. So usually these proximal tibia fractures are a result of a road traffic accident. Most commonly it is a high energy trauma, usually in young patients. Of course, it is not rare to have low energy trauma in elderly people. Usually these all forces, varus valgus and axial and rotational forces, all they come into play to cause typical pattern in a particular patient. Suppose there is a vertical loading, usually split fracture happens without depression. If there is vertical loading and bending, split depression fracture can happen associated with wedging. And if rotational forces are added to this, then you will get a comminution in metaphysis and diaphysis like type 5 and type 6 Shadgar. So whenever a patient presents to a emergency room, of course, we'll have to manage that particular patient based on ATLS protocol. You'll have to stabilize the patient first. And once everything has been done, you have ruled out all other associated injuries, you should pay attention to the particular fractured limb. And first and foremost thing you should look is how is the soft tissue. So what is the status of the soft tissue? It's not uncommon for this proximal tibia fracture, being a metaphyseal fracture, to come with a tense swelling and sometimes with blisters and everything. You should, at any cost, you cannot miss compartment syndromes. There is a simple test for that. If you measure this ankle brachial index, and if you found that it is less than zero 0.9, and then you should advocate an urgent arterial study. If you measure blood pressure at ankle and if you measure blood pressure at arm level, the ratio of it is called as ankle brachial index. And if it is less than zero 0.9, you should advocate an arterial study. Now, in radiological assessment, like in every other cases, we'll get plain X-rays first. In articular trauma, you should get AP, lateral, and both oblique right and left oblique views. And then this is a specific view which is advocated in proximal tibia fracture, considering that posterior tibial slope which we were talking about, and it will give an idea of the articular surface. CT scan is the most commonly done investigation in proximal tibia fracture. It has revolutionized the management of tibial fracture. It has helped us to understand this proximal tibia fracture in a better and better manner. Whenever you are planning to get this CT scan in a comminuted fracture, or if bicondylar fracture, you should always put some kind of traction and then get the CT scan done. So innocuously looking fractures in AP and lateral X-rays, they can have a severe depression, and you can also identify the fracture line from where it is entering and exiting in the tibial rim. So CT scan gives a valuable information in management point of view. The use of MRI has also become very common these days for soft tissue evaluation. There is a paper by Abdel Hamid. They had done a retrospective study of 98 cases, and they had found that meniscal injuries were common in all type of fracture, whereas ACL injuries were common with Shadgar type 4 and type 6. So identifying these injuries, soft tissue injuries, is very important in functional outcome wise, because if we identify these injuries in time, we will be able to manage them. And after putting an implant, after operating a fracture, identifying these injuries by getting an MRI done becomes a little difficult. This is an age-old classification which we all are familiar with. Shadgar had described this classification in 1970. It has divided into proximal tibia fracture into 6 types. First type is lateral condyle split fracture. Type 2 is split depression. Type 3 is pure depression. These are all lateral condyle fractures. Type 4 fracture is of medial condyle fracture. Type 5 is a bicondylar fracture, and type 6 is a bicondylar fracture with metaphyseal extension. AO has also described these fractures as like everyone else. The type A are extra-articular fracture, type B are partial articular fracture, which corresponds to Shadgar 1 and 4. Type C are complete articular fractures, which is type 5 and type 6 Shadgar classification. Then there is a beautiful paper by Liu et al. In 2010. They had described this in Journal of Orthopedic Trauma. They had introduced a concept of posterior column. They had divided this axial cut of proximal tibia from posterior tibial crest, an imaginary line from posterior tibial crest to this fibular crest. And this area, whatever happens in this area, they had described as a posterior column fracture, along with this medial and lateral column. If there is an articular compression and a fracture in that particular column, they had advised a separate stabilization of that fragment. So pure depression fracture, like type 3 fracture, where there is no associated column fracture, it is called as zero column fracture. Type 1, type 2 Shadgar are one column fracture. And this, based on different configuration, they have divided in these into different column fractures. Another paper in 2018 injury, they had done revisiting of Shadgal classification. Whatever Shadgal classification is there, they had added some more information based on CT scan. Similarly, they had also made an equator to divide this proximal tibia into anterior and posterior type. They had taken landmarks of this fibular collateral ligament. One point is taken anterior to it, and this is medial, superficial medial collateral ligament, and posterior point of it is taken, and this equatorial line is drawn, and then it has been divided into or four columns. This is anterior, this is posterior, this is medial, this is lateral. So four columns: anteromedial, anterolateral, posterolateral, and posteromedial. They went ahead, little ahead, to define the primary fracture line. Suppose the fracture line is increasing, entering the fracture from anterior side, and if it is exiting that posterior rim on the posterior side to the equator, they had denoted that this is annulation P. This is A, this is P. Also in sagittal view, they had noticed from where that fracture line is exiting in metaphysis. If it is exiting anteriorly, it is denoted by AX. If it is exiting posterior to this equator, it will be denoted by PX. And this triangle, whichever triangle is formed by A, P, and AX, will define the primary fracture line and the plane of the fracture. Why this is important? Because recognition of primary fracture line is important, because that will determine the hardware placement, where you should put that hardware in order to make the fracture stable. Purpose of every classification is to increase its reproducibility and advocate some treatment plan based on that classification. So this classification is very useful. Another example, if the fracture line is completely posterior, if it is entering here and exiting there, in totally in the posterior medial quadrant, and if you look at a sagittal view, it is also existing in the posterior column. So this whole PPPX, this fracture plane, it's posterior medial fracture, and you will be applying a plate in this area and to buttress it. So this we will be sharing all these papers with you as a handout at the end of the course. I would advise you all to go through all these papers. They are very useful and they will give a valuable information. Now coming to the management, which all fractures can be treated non-operatively? All lateral condyle fractures with an articular step of less than 3 millimeter and condylar widening less than 5 millimeter can be treated with long leg cast for 3 weeks, and then partial weight bearing can be started at 3 weeks, and full weight bearing can be started at 6 weeks. Operative indications, all medial condyle fractures need to be operated because medial condyle doesn't tolerate any kind of displacement. Lateral condyle fracture with an articular step of more than 3 millimeter and condylar widening more than 5 millimeter. Obviously, open fractures and with compartment syndrome fractures, they need to be operated. Person who has multiple injuries also needs an operative intervention in order to make him mobile as early as possible. Like anywhere else, treatment principles are going to be the same. Articular surface needs to be anatomically reduced. Metaphyseal and diaphyseal areas, you just have to restore length, axis, and rotation. And whenever you find that soft tissues are also injured, like menisci, you have to repair them at earliest. How should that operative setup be? A patient is usually operated in a supine position. This radiolucent triangle placed underneath can be very handy in case of dual incisions. You can apply a high thigh tourniquet, and CM should come from the contralateral side of the table. Approaches should be fracture specific. If the fracture is medial, you will approach it from medially. If the fracture is lateral, you can approach laterally. Then for bicondylar fractures, dual incisions do give a better result. This was the conclusion by David Barai et al. They had published a paper in 2006, JBGS. They felt that this dual incision, anterolateral and posterior medial combined, it gives better result in bicondylar fracture by getting a proper approach to a particular fracture. Anterolateral approach, these are the landmarks for anterolateral approach. You can take a straight parapatellar lateral incision or a lazy incision. This is Gerdy's tubercle. IT band is attached over here. You can curve your incision like this in the direction of the IT band fractures, fibers, and then continue it distally. Whatever incision you will take, you will open it internally and do a submeniscal orthotomy to get access to lateral condyle. Posterior medial incision approach incision is taken at the posterior tibial crest. This is pes anserinalis. Pes anserinalis is anteriorly retracted, and gastrocnemius is posteriorly, and you will be get access to this posterior condyle fracture. Most of the time, you don't have to do a posterior condyle arthrotomy over there because these are usually extraarticular fracture with a apex pointed downward. So only buttressing will help in such cases. Now we'll see management of each fracture one by one. Shadgar's type 1, they are the only split fractures of lateral condyle. They can be approached by open way or percutaneous way. You can get away with a lag screw as well. But whenever you are putting a lag screw, ideally you should protect in cast, and any kind of displacement you should ideally convert it into a plate. So plate application is always better. Of course, intact fibula will also play a role. If this fibula is intact, then that means this it will add as a buttress to this tibial condyle. In type 2 fractures, these are the split depression fractures. You have to elevate the bony fragment, put some bone graft, put raft screws, and plate it. Type 3 fracture, usually these are the pure depression type of fractures without any rim impaction. If there is any rim impaction, you have to stabilize that component. By the principle wise, one can make a cortical window over here and elevate these depressed fragments, put bone graft, and put lag screws. But as I said, if this articular depression affects any rim, anteriorly, posteriorly, or laterally, we have to stabilize the column with plate. There are various ways by which you can make a cortical window. You can make multiple drills and use punch to elevate this fragment. Or this is a technique described by American Academy of Orthopedic Surgeons. They put guide wire, check it in anteroposterior and lateral view for proper placement, and they use DHS remols to make a track, and then they will be disimpacting that depressed fragment and putting bone graft from there. Next fractures are type 4 shoulder fracture. Usually these are the high energy fractures associated with major road traffic accident or something like that. So you will have to bear in mind that usually these fractures are associated with mild degree of knee subluxation, and there are high suspicion should be high index of suspicion should be advocated for popliteal artery injury and peroneal nerve injury because of this knee subluxation. And usually these fractures are associated with the posterior medial component as well. So you will require two plates. One is medial and one is posterior medial. Posterior medial is approach and two plates. For bicondylar fractures, usually these fractures are associated with a lot of soft tissue edema, soft tissue swelling. It's very common to see blisters and everything. In such cases, it's prudent to delay the surgery in order to make soft tissue stabilize. How will you come to know whether soft tissue has stabilized or not? You can see that wrinkling after maybe 2 weeks or 3 weeks, and then you can go ahead with the surgery. For small blisters, you can apply silver sulfadiazine. For large blisters, it should be aspirated under aseptic precautions. Few surgeons do a stage surgery. In stage 1, they just apply external fixator. External fixator works beautifully because it will align the fracture, it will align bony fragments, and it will prevent further soft tissue compromise. And then once the soft tissue gets stabilized, you can go for a definitive fixation. For type 5 bicondylar fractures, usually there is a continuity between shaft, metaphysis, and joint in type 5 fractures, and only the condyles are fractured. So here you will require, you need to have buttress for all both the condyles, medial as well as lateral. So now there are some controversies whether to apply a bicondylar plate or whether to go for a bicondylar plate or unicondylar locking plate will also do. So these are the three papers by Barai in 2004, Ellinger et al. In 2018, and this Meng Hossan Lee paper in 2014. We have drawn some conclusion based on that. They have said that bicondylar plates have a better outcome, but one of them has to be a lock plate. If you want to go with ahead with a unicondylar locking plate, then unicondylar locking plate on the lateral side, then you need to see that medial buttress has been achieved in order to make the medial condyle stable. You have to check intraoperatively whether that there is a bone to bone contact on the medial side or not. If it is not there, then buttress plating will be required. Also, they have found that unicondylar locking plate are not sufficient unless you use polyaxial screws. If you are using a lateral condyle plate, locking plate, and if you are using only monoaxial screws going in one particular plane, axis, then it won't be enough to get a good purchase in medial condyle to prevent that varus displacement. And most of the time, as I had just mentioned, that there could be a coronal component as well. So you need to have polyaxial screws going in different directions to hold that medial condyle in a proper manner. Then and then only you can get away with a unicondylar lateral locking plate. Shadgar type 6 fractures are usually like I said in type 5. This continuity between the shaft and joint has gone because everything is comminuted over here. But if you analyze it with a good CT scan and everything, you will find that medial condyle is usually simple fracture. It's a major chunk and simple fracture. So you can build this medial fragment and get the continuity first, and you can build lateral column based on that medial column. Of course, this femoral distractor are a very useful tool intraoperatively to get a ligamentaxis and get the alignment right. Fix medial column first, do provisional fixation for all the remaining fragments, and build a lateral column on medial column. So this has to be your this thing sequence of fracture fixation. Instruments are very important. You need to be aware of these instruments. These are very handy. These are the bony clamps. Femoral distractors have to be kept ready. Bony punches to punch out fragments from its displaced place. These small clamps are also useful. You need to order them pre-operatively. What should be post-op protocol? Patients, if you are confident enough that you have achieved a stable fixation, early active movement should be encouraged, and it should be supplemented with continuous passive motion by CPM machine. At rest, it's preferable to keep the leg in extension, because if Posterior capsule gets contracted, it will give rise to flexion deformity, maybe of 10 degree or so, and it will be very difficult to correct that deformity later on. Toe touching can be started immediately based on pain tolerance, and it will be continued for 12 weeks, and full weight bearing can be started after 12 weeks. Role of external fixator, we have just seen, it restores and maintains length, axial alignment improves, improved bony position of bony fragments, and it reduces further soft tissue damage. Take-home messages: for a sagittal plane fracture, single lateral locked plate is sufficient. For coronal plane, posterior medial buttress is must. Preserve and repair the menisci as early as possible. Whatever you do, prevent varus alignment and beware of soft tissues. Thank you. In case you have any doubts about this particular talk or any other doubts, you are feel free to ask your questions in our dedicated WhatsApp group. We have made a dedicated WhatsApp group for advanced traumatologists, as you are aware. So feel free to ask your questions over there, and we will be happy to answer your questions. Take care. Thank you.